eyes without discharge, and he does not have the severe calf muscle pain typically seen in leptospirosis.
Okay, got it. What about dengue fever? It's highly prevalent and causes severe thrombocytopenia.
It does, but dengue usually presents with severe bone-crushing joint pain, a distinct macular rash, and retroorbital pain. The virus inflames the vascular beds behind the eyes, making it painful simply to look around.
Oh, ouch.
Yeah, but our patient doesn't have those classic signs.
Yellow fever is another vector-borne suspect that causes massive jaundice, right?
True, but the AST and ALT pattern in yellow fever is usually much higher, often in the thousands, reflecting fulminant hepatic necrosis. Plus, we aren't seeing the classic hemorrhagic bleeding tendencies yet.
Okay, well, could it be typhoid fever, given the initial diarrhea and vomiting?
Typhoid is possible from the travel history, sure, but the fever pattern is wrong. Typhoid typically presents with a stepwise progressive fever that stays elevated, not a cyclic 48-hour spiking fever.
Ah, the ticking clock again.
Exactly. We would run a blood culture to be absolutely certain, but clinically it just doesn't fit the rhythm.
Then there is babesiosis, which also causes hemolytic anemia and thrombocytopenia.
Babesiosis is an excellent mimic, actually, but it is typically associated with tick exposure in specific regions of the United States, like the Northeast. More importantly, when we look under the microscope, babesiosis forms a distinct Maltese cross shape inside the red blood cell, which is entirely absent here.
So we are left with a very specific, undeniable triad, really. The 48-hour cyclic fever, the active intravascular hemolysis, and the severe thrombocytopenia. All arrows point directly to malaria.
Exactly. Pattern recognition cuts through the noise of all those overlapping symptoms.
So with malaria as the prime suspect, we transition to the diagnostic tools. We need to unmask the exact species because, well, that changes everything about the treatment.
It absolutely does.
Let's clearly define the specific microscopic evaluations for our listeners' clinical vocabulary.
Right, so we rely on two different types of blood smears. First, the thick smear.
And the thick smear acts as a concentrator. The laboratory intentionally lases or bursts open the red blood cells on the slide. This concentrates a larger volume of blood into a smaller area, significantly increasing the sensitivity. It simply answers a binary question. Are parasites present in the blood?
And once we confirm they are present, we need the thin smear.
Right. The thin smear has a completely different job. The red blood cells are left intact. This preserves the cellular morphology, allowing the pathologist to identify the exact species of the parasite based on its shape and to calculate the percentage of infected red blood cells.
And let's enunciate that term for calculating the percentage, parasitemia.
Parasitemia.
Yes, parasitemia. And the initial findings on this patient's thin smear were absolutely staggering. They revealed a massive 16% parasitemia.
Wow.